All right. Hey, everyone. This is Jeff Young, the kinesiologist. And obviously, or for those for those of you who don't know, the purpose of this recorded Zoom video is for me to read off the questions that I was not able to answer following my presentation in Knoxville because of time limitations. And so there was like 6 or 7 questions that were asked, and Jenny decided that the best way to go about it would be to do what we're doing right now, this Zoom recording. And so what I'm going to do is I'm going to one by one read off the questions and then give my answers to each one. But let me preface by saying that a short Zoom meeting like this with me, first of all, these were great questions and important questions. But a short Zoom meeting with a Zoom, I'm sorry, with short answers to the questions are not going to do justice, or the justice that needs to be done to answer several of these questions. So the best I can do today is give a general overview. But the great thing about these questions is, and my involvement with the AOC PM&R, is that I can actually use some of these questions as topics for the approximately once every 3 weeks meetings that I'm having with the med students. And so I can answer these questions in more detail, and then they'll be hopefully posted up on the site. So I just want to kind of preface and let you know, so that you don't get mad at me, that I'm not going to be able to go into great detail with the answers. So please just understand these are general overview answers, and you're more than welcome to send me an email or hop on a call to answer these in more detail, or you can wait until I submit videos or through the Zoom meetings with the med students to get more detail on the answers. So with all that said, question number 1 is, how would you adjust the program with someone with a total joint replacement? And with some of these, first of all, I'm going to try to fly through this as quickly as I can. But just to make the answers more clear, with some of these, I'm going to do a quick share screen. So give me a second here. There we go. So let me do a quick share screen. Okay. So my answer to this question is that I always look at things through the eyes of the 6 components of a healthy musculoskeletal system. And so when it comes to a total joint replacement, obviously this is very general because we could be talking about knee, hip, or shoulder, for example. But the first thing I'm going to do is, and the most important thing, is to restore mobility. So since I am on the post-rehab side and I'm not a physical therapist, it's going to be assumed that by the time the patient gets to me, there's going to be at least some fairly significant range of motion restored, or hopefully in a perfect world situation, all of it's going to be restored, and that the pain and any swelling that existed is either completely gone or it's negligible. So we first have to assume that little to no swelling or inflammation, mobility has either been restored or close to being restored. But the bottom line is, what I'm personally going to do is I'm actually going to start with a range of motion assessment before I even think about putting them on a program, whether it's knee, hip, or shoulder, it doesn't really even matter. I'm going to start with a range of motion assessment so I can see where they might have restrictions, because yes, we can kind of begin strengthening in conjunction with a flexibility and mobility program, but obviously you want to have mobility and flexibility restored to at or near normal before you really begin emphasizing the strengthening. So the point is that the first thing we have to tackle is the mobility. But once we get that to at or near normal, or assuming that it is at or near normal, then the components of a healthy musculoskeletal system include neuromuscular control, motor control, or what physical therapists like to call neuromuscular re-education, all of which just means establishing proper form and making sure that proper form is a habit. And then there's strength endurance, joint stability, and posture and alignment. So with all that as a preface, the answer to the question is that I'm going to do a stop share and one other quick share screen. So one of the things I mentioned in my presentation this past weekend is that when it comes to designing programs, there are two phases. One is the initial program design, and the second is how you're going to progress out of it once they've completed the initial familiarization phase, or what's known as the adaptation phase. So the first thing I'm going to do is start them with basically with what this chart says, which really mimics physical therapy. So I'm going to start them somewhere around 10 repetitions per set. And the whole purpose of this phase, which could last for weeks to months, is to determine their available pain-free range of motion, teach them the names of exercises, proper form, flow of a session. I'm using light loads. So I'm using what's called RPE scales to determine their initial loading and making sure it's safe. And then during the course of this phase, I'm going to slightly increase their intensity, or in other words, how much I load them up and or how close I take them to muscle failure. And then they're going to be finished this initial phase once they've shown that they've adapted to some level and they understand proper form. And then from there, we're going to progress. And just generally speaking, the way we're going to progress is something like this. I'm going to move them to 12 to 15 repetitions per set, keep them there for a 3 to 4 week phase. Within this range, this load range, I'm going to try to increase their strength, which will prepare their mind and body for when I drop 2 repetitions to the 10 to 12 repetitions per set, stay there for a phase, and just continue to do the same thing down to at least 8 to 10. Whether I go to as low as 6 to 8 is going to be an executive decision that I would make for my, along with the patient. But the point of it all is that I'm actually not going to vary things too much, even though it's a major surgery and joint replacement. I'm not going to vary things too much as compared with how I would train somebody else in the sense of the overall concepts. I'm still going to make sure that the mobility is there. And once the mobility is there, there's only 2 things that's left. And that is strengthening and making sure that it's conservative at first, and then we start to progress over time. And then the other one is neuromuscular control. And that's going to vary a lot depending on whether it's knee, hip, or shoulder, because for instance, for the knee and the hip, the neuromuscular control is also going to include a lot of balance exercises and force absorption exercises like step downs, etc. Whereas you don't have to do those types of things with the shoulder. So let me just review that question, make sure I answered it thoroughly. And yes, so that's how I would adjust the program for someone with total joint replacement. Start low, progress slow. Exercise selection is a really important part of it. So that's going to be part of the adjustment as well. Might want to start them on leg press early on just to get a baseline of strength before we start to progress them to maybe body weight squats and then loaded squats. And then in a perfect world situation down the road, we want to, if possible, move them to multi-directional lunges and step ups and things like that. So there's question number 1. Question number 2, I'm going to read it, but unfortunately is outside of my area of expertise. So I'm not going to be able to answer it, but I at least wanted to acknowledge the question. And it is, how would someone modify a program for a para-athlete with a neurological condition such as cerebral palsy or another associated dystonic issue? And unfortunately, I've worked with athletes, but never, from a special population standpoint. So unfortunately, that is outside of my area of expertise, and I apologize that I can't answer that question. The next question: is there a resource that would allow one to locate exercise professionals that share your approach in their own community? So, man, oh man, I was saying to Betsy Hilt just prior to the recording of this that I literally just got off a call with a vice president of the American Heart Association, who leads this working group that I'm a part of. The organization is called the Physical Activity Alliance. The working group is called a Physical Activity Assessment, Prescription, and Referral Working Group. And this working group, basically, these are the discussions that we're currently having within this working group. How do we make this connection happen, and how do we make it efficient, and how do we make sure that when physicians refer patients to fitness professionals, that they are qualified, they've been vetted, etc. And it would honestly take me 20 minutes to go into a detailed and justifiable answer to this question, which I just don't have the time to do. So the gist of it is, outside of myself, and I'll get back to myself here in a second, outside of myself, there are local, like you could literally Google find a trainer in my local area, and there will be websites most likely that will come up, unless you live in a rural area. There will be websites that will come up that can help you find a trainer, or you can go to fitness organization websites such as the American Council on Exercise. They have a really good database, and you can literally just go to their website and type into their search box, find a trainer, and they'll have actually nice database with their fitness trainers will have pictures and bios and stuff like that. And you can just look it up by zip code. There are other databases for other fitness organizations as well, like the American College of Sports Medicine, the National Academy of Sports Medicine, something called the United States Registry of Exercise Professionals. But honestly, they are not clinician friendly. They don't give you enough information. And this is some of the stuff that we're trying to work on in this working group that I'm involved with, which leads to the last part of the question. I actually can provide this service, and I'm willing to provide it at no cost. So I'm really involved with the ACSM, the National Strength and Conditioning Association, the American Council on Exercise. I have a really large network throughout the country. And while I can't make guarantees, I think that chances are pretty high that if you were interested, you literally could just contact me through email or whatever. Let me know where you live, and maybe we can exchange a couple emails where I just find out more of, what you're looking for, what type of patient you want to refer, their conditions, etc. And then I can reach out to my network and maybe even help a little bit with the vetting process, so that I can make sure I don't find you some trainer who works at a commercial gym that just isn't qualified. So I absolutely can provide the service, and please reach out to me if that's something that you're interested in, and we'll talk about it in more detail. Next question. And by the way, there are 7 questions, one of which I couldn't answer. We are now on question number 4, which is, does insurance ever cover fitness professional services? Can patients use an FSA or HSA with a doctor's prescription to cover the expense of a Fit Pro? So there's actually 5 tiers to this answer, but I, once again, can go through these pretty quickly. So currently, it is an out-of-pocket expense, unfortunately. But please understand, and once again, I can only give a general answer here. I easily could go into detail, but unfortunately, that would take 20 minutes. So it's an out-of-pocket expense, which is obviously a problem. But please understand, there really are a lot of ways that the cost can be reduced, which in my opinion, the physician should know this information so that they can relay it to their patient, so that the patient doesn't think that it's some sort of all or nothing situation, so they can at least make an informed decision. And some examples would be just to let the patient know that first of all, that this is an investment and not an expense, that we can set you up with a qualified exercise specialist, and literally in just 5 to 10, if you're willing to invest in just 5 to 10 sessions, at least they can get you started off on the right foot, answer the questions for you so that we can get a safe program designed for you, even if it's just a home exercise program. And then, for instance, they could just do occasional check-ins, like once a month, once a quarter, or something like that. So that it doesn't have to be this ongoing weekly expense of 2 sessions per week, with, even 1 session per week, which so many people can't afford. So that's one thing. There's also virtual sessions, which are way cheaper than in person. There's partner, like training with another person and partnering up and sharing the cost of the session, or group training. There's also reducing the time of the session from 60 minutes to 30 minutes. While not ideal, at least it's a way to get things started and reduce the cost. So that's one part of the answer. Second part, a lot of people don't know this, but actually many insurance companies like your Blue Cross, your Aetna, et cetera, they actually do offer reimbursement. So it's not a copay situation. The patient is still going to have to pay out of pocket. And it also does depend a little bit on not only the the insurance company, but also the individual policy. So because of that, the patient themselves is going to have to call their insurance provider and ask them, does my plan currently cover reimbursement for fitness sessions? And then if the answer is no, they're going to have to ask how can I get that on as part of my plan? If the answer is yes, then they just need to get more information on what that means. But typically what it does mean is that the patient needs to show the insurance company that they've performed, for example, 20 sessions over the scope of like a 4 or 6 month period. And they'll have to turn in some paperwork to be able to show that. And then they'll get reimbursed. And then how much they get reimbursed is dependent on the insurance company. It might be 200, it might be 300, it might be 400. But the point is that this is something that a lot of people aren't aware of, and it does at least help reduce the burden of cost. Part 3. There is something called the FIT, P-H-I-T, the FIT Act legislation. It is currently pending in Congress. Please go to fitamerica.org, so P-H-I-T America.org, to learn more. And this actually is the first time after decades of trying to get this passed, or through the legislative process. This is the first time that actually looks like it may get approved. And if it does, then insurance companies are going to be forced to reimburse for a lot more fitness type services. So please go to fitamerica.org for more information. Once again, the next part of this question is that I am part of this Physical Activity Alliance working group, and that we are talking about this stuff. So, and creating a plan. And the plan is a 3 to 5 year plan. We are developing CPT codes. We are in connection with the American Medical Association to get these approved. It's probably going to take 3 to 5 years. It's a very complex thing with all types of red tape, but we do feel confident that somewhere in the 3 to 5 year period, CPT codes are going to be approved, so that this is a copay situation for patients. And then lastly, and this is going to give me a second here because this is going to require another quick share screen. So I have a colleague named Sheila. She's a physician assistant. She works in Richmond, Virginia, and she does something called shared medical appointments. And I'm only going to show you two quick slides. But these first 2 pictures are just an example of what they do in their clinic. It's cardiac rehab. It's actually a cardiac prevention clinic in Richmond. And what they do, and I actually don't know a ton about this, but the total time of the appointment is typically 60 to 90 minutes. The medical assistants do the meds and the history update and the vitals. It can be a one-time thing or a series. But the thing is that it has to be the provider's actual practice. So this has to occur in the clinic with the provider actually there. And then the provider or the medical assistant will, do some vitals. And then at that point, they can bill for it, which just leads to the second slide. And that is, and this is outside of my area of expertise, but this is the language you guys speak. Provider documents and bills, the EM code is 99213 or through 95. Blah, blah, blah. So the reason why I point this out is A, it's part of the answer to the question, and B, Sheila presented on this. It's like a 35-minute presentation for the American College of Sports Medicine's Greater New York Regional Chapter Spring Conference just several months ago. So I actually have her video. Well, it's also up on YouTube. And if you're interested in more information on this, please send me an email and I will send you the link to this video where she describes exactly what you do. And if you still have questions, reach out to me. And her and I talk almost on a daily basis. So I can either connect you with her, or you can just let me know the questions that you have, and I will answer. I'll ask her, and then I'll get back to you right away. So there's the answers to question number 4. Question number 5. This one's pretty easy. Should men and women train differently? The broad answer to that question is no, they really shouldn't. And now here's the reason why. There is a couple outlier situations, or really just one, but the reason why is because the governing body guidelines, the American College of Sports Medicine and the National Strength and Conditioning Association, everyone should strengthen every major muscle group in their body twice per week, whether man or woman, across a spectrum of repetition ranges, whether, once again, whether male or female, typically in the 6 to 15 or 4 to 15 repetition range. And then when you start getting into sets per exercise, rest periods between sets, and these other variables, they are identical for men and women. And even when you start delving deeper and getting into, well, what about for special populations and the special considerations needed, the answer is still, it's, like from a disease standpoint, um, for a diabetic, you're still going to want to check their blood sugar, or at least have a good idea that their blood sugar is in the safe range. You're still going to want to, whether they're male or female, you're still going to want to make sure that they're hydrated and that they've had some food, some fuel prior to the session, etc. My wife has multiple sclerosis, as many of you know, and it doesn't matter if it's male or female. You're still going to want to have a cool environment, longer rest periods between sets, make sure they're hydrated, etc. So the answer, even from a special considerations for special population standpoint, is still no. And even from a musculoskeletal standpoint, you're still going to hit your knee friendly exercises for knee pain, such as bridges and straight leg raises with an ankle weight and things like that. So there's still, your joint friendly exercises are still going to apply no matter what your gender is. The only outlier really is pregnancy. And so obviously, while you're during pregnancy and immediately post pregnancy, there's obviously going to be differences, which I can get into through sending links if you want, through email if you want more information on that. And then some people might say, well, what about your menstrual cycle? There is actually a half decent amount of research on that. And yes, it's absolutely true that depending on where a female is within her cycle, she might be a little bit more fatigued and you might need to make adjustments because of that. But the truth is, that still falls under the umbrella of the concept that I mentioned in my presentation called readiness to train. And a good coach, no matter male or female, healthy or special population, they still should be asking their client prior to every single session without fail, how do you feel today? How did your body respond to the last workout? Have you eaten? What did you eat? When did you eat? Did you take your medications? Things like that. So no matter what, the even something like menstrual cycle is still going to fall under that umbrella, because if they're feeling fatigued, for example, maybe they have a slight headache or whatever the case may be, if the coach is asking them those questions, which they should be, then the coach is going to be able to determine, okay, in today's session, we're going to back off, or maybe we aren't going to train at all. Or maybe despite where they are in their menstrual cycle, they're feeling okay. And so based on the answer to those questions, we're going to go a little harder today. So technically it's a difference, but when it comes to application, it really isn't a difference if the coach is doing their job. All right, we got 2 questions left. This one, which is, what type of nutrition program or plan do you recommend for people looking to gain strength / muscle mass? So let me preface by saying that I have to be really politically correct when answering this question, because nutrition science is all over the place and views on nutrition are all over the place. Some people are keto, and the next is carnivore, and the next is vegan or vegetarian, and on and on. And there's no way I can answer this question within the scope of all these different views. But what I can say is that when it comes to gaining strength and muscle mass, so when it comes to gaining muscle mass, you need to be in a caloric deficit. I'm sorry, caloric surplus. You aren't going to gain muscle mass either at all, or it's going to be insignificant unless you are in a caloric surplus. So that's step one, is just to make sure that the person is eating more calories or consuming more calories than they are burning. And they're also going to have to understand that it's impossible to put on all your mass in the form of muscle. Some of it's going to be put on in the form of fat, but we can minimize how much if we're doing things right from a caloric standpoint and from a protein standpoint. And then also make sure that you're resistance training, obviously. So I'm going to do another quick share screen. Give me a second here. Um, huh. All right. Well, yeah, this. Okay, here we go. Sorry for the delay. And that is not the right. Here we go. So this article, which I, obviously highly recommend that you take a look at. Recent perspectives regarding the role of dietary protein for the promotion of muscle hypertrophy with resistance exercise training. So that's really going to provide you an evidence-based answer to your question. And the gist of it is that you want to make sure that your protein intake is somewhere in the, I think this article says 1.6 to 2.2 grams of protein per kilogram of body weight. But the truth is an organization called the International Society of Sports Nutrition puts out a ton of information on this topic. They've even have position stands on this topic, and really it kind of depends on the person's activity level and some other variables. But generally speaking, it could actually be as high as 2.5 grams of protein per kilogram body weight or above. And so now we'd started delving into things that's just outside the scope of the answer to this question, at least in this Zoom video. But you really need to start, then the first thing you do is you look at what their total caloric intake is going to be, such as 2,500 calories a day. And then you got to start doing the math. Then you have to start doing the math on how much do they weigh in kilograms, what is the calories per gram of protein, and calculate that part out. Then you have that part of the pie, and you know how much protein that they should be intaking within that 2,500 calories from a protein standpoint. And then from there, you can figure out your carbs and your fat. But otherwise, it's going to be dependent on what they eat, what they have access to, what they enjoy, which is just too long for me to answer. Which now leads to the last question. Can patients use a different scale than rate of perceived exertion to pick their weights? Can you go off a percentage of 1 rep max instead? So interestingly, and this goes to my next article to show. I don't know why this thing is coming up here. So this literally just came out a month ago. And it's called Training for Muscular Strength, Methods for Monitoring and Adjusting Training Intensity. And what they do is they go through different methods to monitor your training intensity, something called the 2-for-2 rule, repetition maximum zones, percentage of 1 rep max, which is mentioned in this question, rating of perceived exertion, the RPE, or something known as repetitions in reserve, something called set repetition best, which I've never used, auto-regulatory, which basically just means do the readiness to train questions, like I mentioned just a little bit ago, and adjust the session accordingly, etc. So if you're interested, check out this article. It goes into great details, just a review article, and it'll give you more insight into the answer to this question. But my answer to the question, let me get out of this, is that you don't have to just use one method. So here's my problem with percent of 1 rep max. I have 2 major problems with it. One, it's a moving target. So as the person increases strength, their 1 rep max is going to increase. So it kind of implies that you're constantly testing the person's 1 repetition maximum and then determining the percent of it. And while that's kind of an old school method now. So while it is a method and it's valid and you can do it, it's a moving target and it's not an optimal method. And then the other problem I have with it is that for special populations, such as people with disease, they're deconditioned, they might be overweight or obese, they have musculoskeletal issues, it implies that we are doing some sort of repetition maximum testing with them, even if it's not 1 RM, even if it's a 4 repetition maximum or 6 repetition maximum. This implies that they have the confidence to do it, that they have the ability to do it, that they can maintain proper form when being loaded up to perform some sort of maximum effort set. And I'm just not a fan of that at all, especially for the general and special populations. And so what I do is I kind of explained in my presentation this past weekend is I kind of merge a bunch of the things that are listed in that article. I'll start off by actually just being really conservative with them and choosing warm-up weights on purpose so that I'm gaining their trust and I'm not scaring them with heavy loads or really intense sets. And instead, I'm just teaching them proper form and just taking the time to see how their body is responding and adapting. And then over the course of time, I will start to move them closer to muscle failure. And that's then when the RPEs ranges will start to apply. But I'm also looking at things like velocity of movement, which is listed in this article as a way to determine whether the set was a true working set. And I also will be using auto-regulatory methods by asking them prior to the session, how do you feel? Or immediately following a set, how did that set feel to you on a scale of 1 to 10? And then I'll adjust the next sets accordingly. If I loaded up a little too heavy, which I better not be doing, but if I did, then I'll back off on the next set if that's appropriate. And if I didn't load up enough based on the velocity of movement of the set and or how they answer, then I might adjust in the next set or two and increase the load. But that's the general answer to that question. And once again, with all these questions, I could really go into a ton more detail. And because these are awesome questions, I'm going to suggest to the student council that I cover some of these in more detail in the Zoom meetings that I am going to be presenting for them. The next one, by the way, is on Monday, the 21st. But I won't be able to cover any of these questions because we already have our topic chosen, which is going to be a little bit on multiple sclerosis and a little bit on shoulder rehab. So with that said, that's it, Betsy. And I hope this answered your questions well. And please email me with more, because this is great stuff and it's great information for me to provide more educational content for the AOC PMNR.